So I'm pleased to introduce our first speaker. So Miriam is a third-year pediatric hematology oncology fellow within our division, and she has continually proven to be one of our most outstanding fellows that I've had the pleasure to work with. She is currently working with Dr. Zhu, who's recently moved to Washington, D.C., and she has moved with him to Washington, D.C. to continue her work within his lab. Miriam has a strong interest in neuro-oncology, which involves her bench science research and eventually her clinical involvement as well, and I'm sure she's going to be an outstanding neuro-oncologist. But Miriam always describes that immunohematology as a hobby of hers, and despite our attempts to convince her to make it her profession, she likes to kind of do it on the side. So with that introduction, she's going to present a very interesting case of recurrent fevers and self-resolving cytopenias in an infant with XIAP deficiency.
Great, thank you. Thank you for that wonderful introduction and for the opportunity to talk here today. I always look forward to an opportunity to come back to the frigid temperatures of Michigan, so this gave me that opportunity. The patient that I'm going to be talking about today is a patient that I first met in 2011 when he was 8 months of age. He was admitted at that time to the hospital with fever, rash, cough, rhinorrhea, congestion. He had also had 5 days of watery diarrhea and was dehydrated on presentation. Of note, 2 days prior to his hospitalization, he'd presented in an emergency department, and at that time he primarily had the rash and the diarrhea. And the rash was initially on his trunk, but then spread to his limbs and his face. He had a CBC done, which showed a white count of 3,000, an ANC of 600, a hemoglobin of 11, and platelets of 120,000. He was treated with ceftriaxone and discharged home. When he returned home, his symptoms continued. In fact, he became a little bit more lethargic and the dehydration started to set in. So his mom returned to the emergency department. At that time, a CBC showed a white count of 2,700, ANC of 500, hemoglobin of 10.3, and platelets were down to 64,000. He was transferred then to the University of Michigan for further management. On review of systems, he had a decreased appetite, decreased energy, and then the other symptoms that I've already mentioned. But aside from that, no weight loss or lymphadenopathy that the mom could appreciate. In past medical history, though, the mother noted that he'd had 3 previous hospitalizations for low blood counts when he was living in Florida. So that was prior to coming here to Michigan. His family history was basically insignificant at that time. He had no immunodeficiencies and no childhood cancers in the family. He does have a half-brother with poorly managed type 1 diabetes to the point where he actually already has peripheral neuropathy as well as diabetic retinopathy, and a father with G6PD deficiency. Social history was also somewhat unremarkable. He lives with his mom, half-brother, and some other relatives. His hospital course here was rather quick. He was only here for about 2 days. He clinically improved, and antibiotics were initially given to him, but they were stopped due to high suspicion for viral etiology. His blood counts also improved on their own without intervention, and at the time of discharge, his white count was up to 6.3. I'm sorry, I didn't put the ANC on here, but his ANC was 2 at that time. Hemoglobin was 10.9, his platelets were 125. We were consulted the day of discharge, and so rather than seeing him in the hospital, we actually arranged for outpatient follow-up, primarily because I wanted to review his records from his previous hospitalizations, as I felt they would be really helpful in evaluating this patient. So the hospital inpatient team helped obtain the records, and I got about 60 pages of records from one of his hospitalizations at 7 weeks of age, and this is sort of a compilation of what I saw. He was in the hospital at that time for a week. The primary symptoms at that time were fever and tachypnea. They did an extensive infectious workup, including HIV, CMV, EBV, parvo, HSV, hepatitis, and influenza, as well as mycoplasma. Everything was negative except for the influenza A rapid test, which was positive, although the PCR was negative. He also had CBC checked intermittently throughout his hospitalization. What I'm showing you here is his admission CBC. He had a white count of 1.9, hemoglobin of 7.7, platelets of 66, and an ANC of 200. Throughout the hospitalization, his counts actually slowly recovered to the point of discharge where they were normal. He had immunoglobulins checked, which were normal. LDH was checked due to concern for a possible malignancy, hematopoietic malignancy, and that was elevated throughout the hospitalization. Interestingly, and this is showing his his counts, but interestingly, they did a ferritin due to suspicion for HLH at that time, and his ferritin was 18,700. They repeated it 2 days later. It was 7,290, which is still quite elevated. So they chose to do a bone marrow biopsy, which showed left shift of the myeloid maturation, but no true hemophagocytosis. So in the notes, they do say HLH was considered, but because the bone marrow was negative, that is most likely not the diagnosis, and he was ultimately diagnosed with viral suppression and discharged home. So I was able to take his past medical history. At the time that I saw him in clinic, he'd already had 4 hospitalizations. 2 of them we were not able to get records for. And when you look at this, what you'll see is the pattern of a low ANC. 2 of them were per mother's report through all 4 of the hospitalizations, as well as a low platelet for at least 2 of the 4 hospitalizations. And then we know of a low hemoglobin at least 1 of those hospitalizations. Most impressively, though, was that ferritin of 18,700, which had not been evaluated further until he came to our clinic. So right now we have an 8-month-old male, recurrent fevers, and self-resolving cytopenias with hyperferritinemia during at least one of those episodes of infection. So when we were thinking about him, we had to come up with a pretty extensive differential diagnosis, and our evaluation was set to kind of help with that. The differential diagnosis that we came up with at that time, we still were thinking about viral suppression, as that is quite common, and it is possible that this was just another viral suppression. But because of his hyperferritinemia and the fact that he'd had recurrent episodes of neutropenia or in hospitalizations for neutropenia, HLH was actually on our differential, and along with that, X-linked lymphoproliferative disorders. We also considered primary immunodeficiency disorders, Evans syndrome because of the drop in the hemoglobin and the platelets. Thalassemia was a consideration, although there hadn't been mention of splenomegaly that we were able to find. And then as contributors, but not necessarily the cause of everything, we also thought of iron deficiency, anemia, and hypothyroidism. So what is HLH? So HLH, or Hemophagocytic Lymphohistiocytosis, is an immune disorder characterized by dysregulation of the immune system. So you get clinical signs and symptoms of extreme inflammation. When patients who have HLH are exposed to a trigger, there's a multi-system inflammatory response that's exaggerated, but it's not effective, which results in a cytokine storm and inflammatory reaction, and you get multiple system dysfunction. So thinking about the diagnosis, they were able to come up with some clinical criteria to diagnose, or clinical diagnostic criteria for HLH. There are 2 ways that you can diagnose HLH. The first one would be through a molecular diagnosis, which we did not have at that time for our patient. The second way would be through the criteria that are listed. There are 8 criteria, and you need to meet 5 of those 8 criteria. Our patient already met fever, splenomegaly, and the cytopenias, even at his 8-month diagnosis. So we decided to run some tests to look for all of the other things that you see on here, including the soluble IL-2R, ferritin, NK cell activity, and then hypertriglyceridemia and hypofibrinogenemia. We chose not to do a bone marrow during this evaluation. So on our further investigation, he had NK cell function, which was normal. His soluble IL-2R was elevated at 4,720. Generally, greater than 2,400 is considered to be diagnostic for HLH. His fibrinogen and triglycerides were normal, and his ferritin was 530, although it had peaked at 782 with our values. I do want to make sure that you note, though, that ferritin was taken after, or that was checked after resolution of all of his infectious symptoms, and so we likely did not catch the peak at this time. His immunodeficiency workup was unremarkable. Everything was normal there. So now that we know that he most likely had HLH or has had potentially 2 episodes of HLH, we started to look at familial causes of HLH or genetic causes of HLH. This is a list of the different genes that have been associated with HLH. The 3 that we were most interested in were perforin, and then the X-linked, so the SH2D1A and the XIAP gene mutations. In 2011, Michael Jordan published in Blood basically a summary of how to evaluate suspected HLH or XLP for genetic mutations. And this is the summary that he published. And we have taken this summary, and actually Jim Connolly has adapted it for our institution. And this is sort of what we follow now for our patients with suspected HLH. So it starts at the top. You suspect HLH, and then after that, the next things that you would send would be a perforin, and then, flow cytometry for perforin, as well as flow cytometry for SAP and XIAP expression, which is what we send for my patient. The flow cytometry is very interesting. So looking at HLH or the flow cytometry, let's see if I can get this to work. So if you look at flow here, and this is just sort of showing how the flow cytometry works. This right here is showing for SAP, and then down here it's XIAP expression. If you look at the control, what you'll see is you'll see 2 bars here. There's one that's gray and then one that's darker. The gray one is the control where they have control beads, and then the darker one shows when you, for this one it would be the SAP protein, antibody for SAP protein. This one it would be the antibody for the XIAP protein. And what you should see in a typical patient is you see a shift in the fluorescence if the protein is present. And so what you'll see in this patient, this is an NK cell or an assay that they did, and you can see that this patient has a level similar to that of the control, so you did not see the shift in expression, so that patient would have SAP deficiency. And we see the same thing here for the XIAP deficiency. So when our patient had flow cytometry done for XIAP, this is what we saw. So here you can see the control, and you'll see the control beads, and then you'll see the shift in fluorescence when you add the XIAP antibodies. With our patient, however, there really was not a significant shift, and you can see the levels down here indicating that this patient really had essentially no XIAP protein present, hence XIAP deficiency. To confirm the diagnosis, we did gene testing and sequenced the XIAP gene, which is the BRCA4 gene. Sorry about that. And you can see here that he did have a novel mutation at the base pair 145. This is also his family tree. So I started putting together a little bit with his family tree, and we were able to test the mother and his brother. He had a 20-year-old brother who was totally asymptomatic. And we found that the mother was a carrier, and his brother actually has the same mutation with XIAP deficiency. Other than type 1 diabetes, healthy and no other issues his entire life. So what are the X-linked lymphoproliferative disorders? There are 2 that have been described, XLP1 and XLP2. As I mentioned before, XLP1 is associated with the SH2D1A gene mutation. XLP2 is associated with the BRCA4 gene mutation. XLP1 results in a SAP protein deficiency, and this is generally expressed in TNK and invariant NK cells. And so the interaction between the SAP protein and the SLAM signaling is defective, and so you get altered lymphocytes as well as NK cell function. There's also a thought that SAP protein has a role in B cells, which is why these patients have deficiencies in their immunoglobulins. XLP2, on the other hand, is ubiquitous. It's expressed in all different cell types, and the mechanism for developing HLH is really largely unknown. We do know that XIAP is an inhibitor of apoptosis, so there's thought that there's an increased susceptibility to apoptosis, but I think that there's still a lot of work to be done in this. XLP1 was first clinically described in 1969 with patients who had hypogammaglobulinemia and malignant lymphoma after EBV. It's interesting, though, I've actually found reports even as far back as 1948, so it's likely that this has been described even prior to that. It was solidified, though, in 1975. It was actually initially called Duncan syndrome because there was a family, the Duncan family, where there were multiple family members who had the similar symptoms. XLP1 has a very classic triad where you'll see fulminant infectious mononucleosis, or HLH after EBV. And then they can also get lymphoma as well as dysgammaglobulinemia, or low immunoglobulins. On the other hand, XLP2 was first reported in 2006. The gene was sequenced in 1996 by our own Colin Duckett, but the actual description of this as being a cause of HLH was not until 2006. And this came about when they had family members, male family members, that were being evaluated for SAP mutations that did not have SAP mutations, and so then they found that these patients had a deficiency in XIAP instead. Looking at the phenotype, in particular for our patient, we were interested to see what the difference is between XLP1 and XLP2, so we knew what to expect. You can see that both types will present with HLH as well as HLH relapses. So they'll not only have one episode of HLH, but they could potentially have multiple episodes, which is what our patient had. Fatal HLH is also possible in both of them, although it's a little bit more likely in the SAP deficiency than XIAP deficiency. The interesting thing that I found was lymphoma. So lymphoma, you'll see in the SAP deficiency, it was part of the triad, but so far XIAP deficiency, it has not been described. And I found a couple other papers since this one, and it still to date has not been described as a part of the XIAP deficiency. In addition, XIAP deficiency has been associated with a hemorrhagic colitis, and there's been some work done on that. I think actually we're going to hear a talk today about that and the possible link between XIAP and hemorrhagic colitis. But that is seen in XIAP deficiency and not SAP deficiency. So what happened to our patient? So since his diagnosis, he's had an additional 4 hospitalizations, making a total of 8 in his lifetime. He's only 3 years of age. Most of these diagnoses consisted of viral infections, although there was one where he had otitis media. Interestingly, with the otitis media, you can see on here that his ferritin level really did not, sorry, that's the wrong one. Ferritin level did not increase significantly, so he likely had a little less of a response with that bacterial infection than some of the viral infections. 2 of these diagnoses also came after immunizations. The one at 14 months of age came after a flu vaccine, although he also seemed to have some viral symptoms along with that. And then the one at 19 months actually seemed to be related to an MMR vaccine that he had received. 7 days after getting the vaccine, he had a fever, rash that looked pretty extensive, extended most of his body, and then he had an increase in his ferritin along with that. For him, I was able to trend out his ferritin. I think this is actually very telling for XIAP deficiency and for any type of lymphoproliferative disorder or genetic lymphoproliferative disorder. What we see here is that for times of illness, particularly with the viral illnesses, you see a peak or an increase in the ferritin, which then goes down to normal levels when he's not exposed to anything. Then it'll peak again and come back down again. So each of these peaks is associated with an infection that he had. This was the initial diagnosis. This is the diagnosis when I first met him here at 8 months of age. This one right here was the diagnosis where he had a fever 24 hours after his flu vaccine. And then you'll see here, this is his otitis media, so not as dramatic. And then you can also see following the MMR vaccine, and then this one he was recently diagnosed and hospitalized for RSV. So our patient, management of our patient. So we do have, I think the most important part of his management has been our alert note. So we have in his chart as well, his mother has a copy of a note stating that this patient has XIAP deficiency and therefore will require additional management when he presents to the emergency department. For any acute illness, we'll do laboratory evaluation within 24 hours of symptom onset. We also would like a physical exam within 24 hours of symptom onset. We have said that she can go to her primary doctor, or that he can go to his primary doctor if the symptoms are not bad, but I think the mother has chosen to come to her ER most of the time. There's close monitoring of symptoms after that, either through close follow-up or hospitalization. And we have chosen not to do blood cultures or antibiotics unless indicated. Long-term management has consisted of periodic well visits in our clinic. Right now, he's at every 6 months. The labs would include EBV PCR as well as immunoglobulins. We have chosen not to vaccinate him with any live vaccines now, given the response after the MMR vaccine, although that's something that I think will continue to be a topic of discussion. And then bone marrow transplant was considered, but we did not find a suitable donor, so he has not undergone that. In conclusion, there's 3 things that I would like for you to take away today. The first is that X-linked lymphoproliferative syndromes should be considered in the diagnosis or the differential of patients who present with recurrent episodes of fever and neutropenia. Additionally, I think ferritin levels could be very helpful in the diagnosis and management of XLP2 and XLP1 for that matter. And patients with XLP2 should be monitored following all viral and vaccine challenges. To conclude, I'd like to acknowledge the Immuno-Hematology Comprehensive Program, say thank you to them as well as the patient and the family. This is actually my patient in there. Whoops, sorry about that. Little guy here with his brother and his mom. And, you know, they've been a huge part of our program, and his mom has been very supportive in allowing us to talk about his or her son, especially in conferences like this. So thank you very much.
Time for one question.
All right. Yeah.
So I have actually 2 questions I'll put into one.
Okay.
So one is, you said that NK function was normal.
Yes.
I wonder what the NK testing done was, and is it really normal? And along with that, you know, in XLP1, there are abnormalities in skewing of maternal T cells. Is that true in XLP2?
I don't know the answer to your second question. The first question, so the NK cell function, so we did the iNKT as well as NKT, or the NK cell function, and it was normal. There have been a lot of reports, especially in XIAP or XLP2, of patients with normal NK cell function. And I guess I can't really comment more on that, unfortunately. I don't really know enough to be able to say much more. But I have found that that's actually not uncommon with XIAP deficiency for that NK function to be normal. So, yeah, thank you.